Okay, so we left off with the ROC curve. We're going to continue with the lecture about screening. Part 8 is about feasibility. Now, it assesses through looking at the aspect of screening program. So to figure out feasibility, you need to look at how acceptable is the screening for the people, targeted people. You look at the cost effectiveness of the screening to see if you actually it makes sense to do it. We kind of like address that um, when we talked about the cost. The subsequent diagnosis required for those who test positive, and you're going to look at the positive predicted value and the negative predicted value also for feasibility. Okay, so let me just remind you again what positive predicted value means. Positive predicted value means that if I tested positive, what are the chances that I actually have the disease? And negative predicted value means if I tested negative, what are the chances that I'm actually healthy? Okay, um, Pap smear, for example, it has a great acceptability, which is great. Amma sigmoidoscopy, which is used to detect colon cancer, it involves great discomfort and thus was not accepted greatly by the population at risk. Moving along, so again, talking about feasibility, the positive predicted value and the negative predicted value. It's important to understand how these factors are calculated, but also what are the things that impact these things. And I'm going to show you two tables. The first table is, is trying to show you how the positive predicted value is highly affected by the prevalence of the disease. And you're going to see that if the disease is pretty rare, then the positive predicted value is very small. And on the second slide, I'm going to show you how sensitivity and specificity of a test affect the positive predicted value. Okay, so here's a table. And in this table, what we're doing is we're showing you this. We're picking a test. So it has a sensitivity of 90% and it has a specificity of 95%. So these two values are constant. It is one specific test that we picked, produced by a certain laboratory, and it's the same one. Okay, but what we're going to do is we're going to use it in different population. The prevalence of the disease in population 1 is 0.1%, very low. In population number 2, the prevalence is 1%. In the third population, it's 5%, and in the fourth population, it's 50%. So the prevalence of disease is increasing. Now look at what happens to positive predicted value. In the first population using the same test, the positive predicted value is about 2%. Yani Anna, if I'm getting screened where the prevalence of the disease is 0.1%, if I test positive, my chances of actually having the disease is 2%. Yani عندي 98% chance of being healthy. So you can understand that it doesn't make sense to screen, right? You're not gaining any knowledge here. When the prevalence of the disease increases to 1%, the positive predicted value reaches 15.4%. When it goes up to 5%, now we're reaching about 50% chance. So if I'm being screened in an area where 5% of the people actually have the disease, and if I test positive, here I have 50% chance that I may have the disease. So it starts to make sense. Now I may consider having to go and getting screened or getting further diagnostic tests done. If the test reaches 50% chance or 50 prevalence of 50% and 50% of the people have the disease, if I test positive in this population, 95% chance that I have the disease. So here, for example, you might start thinking maybe we do not need further diagnostic tests. Okay? You notice the 5% where the positive predicted value really shifted and it reached 50%. So it's kind of like related to the idea where we talked in the previous slides that the disease has to reach a certain level of prevalence. Okay. Now, the second slide has to do with showing you how the sensitivity and the specificity of the test impact the positive predicted value. So you have table 3.3 and 3.4, and in both table, 1,000 out of the 100,000 have the disease. So you see that you have 100,000 people and 1,000 people actually have the disease. And again here, 1,000 people is the total, and 1,000 out of the 100,000 people, 1,000. So the prevalence this time is constant, okay? In the previous slides, we were changing the prevalence. In this slide, the prevalence is constant. The prevalence is not changing. It's 1%. But what's changing is the sensitivity and the specificity of the test. Look, we have a sensitivity of 90% and a specificity of 95. Whereas here we have a sensitivity of 90%, so again the sensitivity didn't change, but the specificity changed to 98%. Look what happens to positive predicted value. It went from 15.4% to 31.3%. Okay, so what is the idea behind these couple of slides? It's just trying to tell you that the positive predicted value, and again, this is a very important value. This is somebody tested positive, and now you're telling them, now that we know that you tested positive, chances are this 70, 80, 90% that you have the disease. Depend on the prevalence of the disease and on the sensitivity and the specificity of the disease, okay? So sensitivity and specificity, in the previous slide, we talked about the ROC curve. If you want to compare, if I want to compare two different tests, which one should I pick? You look at the ROC curve. And if you want to look at where do I draw the cut point, we talked about that as well in the ROC curve. Okay, so moving along, effectiveness of the test measures the impact of the screening program on the public health. Okay, again, effectiveness is a very important word that you need to learn, and it's applicable in different courses as well. There are two words that you may at this time be using interchangeably, and you need to start using them correctly. The word efficacy and effectiveness. So if something has efficacy, we say it's efficacious. And if something has effectiveness, we say it's effective. So what's the difference between efficacy and effectiveness? Efficacy is if the test is actually a good test. Carry it out for a drug if a drug actually works. That's efficacy. Yani under ideal conditions. If the drug works, that's efficacy. Effectiveness is under normal condition would it work. So effectiveness is once you take something that efficacious, yani it has efficacy, and you release it in the world where you know people don't follow protocol, people don't the doctor advice of the doctor, or people don't like the taste, or because of side effects, etc., etc. Will the drug still be able to control the disease? I know I moved a little bit away from testing, but just so that you understand the difference between efficacy and effectiveness. So efficacy, if something works under ideal condition, under controlled condition, and effectiveness is now that we know it has efficacy, will it still work, or how much of it will it still be working when we change to the normal, when other factors come into play, human factors and other characteristics. Okay, so to be effective, a program, and here we're talking about a screening program, it has to have a good screening test and a good program. So when I say a good screening test, yani this test itself should be good. And here I'm talking about efficacious and efficacy. So the test has to be a good test. And then the good program, meaning that now that I get a good test, will I have other elements that would support it to be able to reach a good outcome? So effectiveness can be tested by comparing mortality rate of those that underwent the screening to those who did not. This is like the typical way of determining if you screen or not. And basically they do large studies where they look at people that were screened and people that were not screened for certain disease. And then they look, for example, at mortality after 20, 30 years. They see what happened to these people. And if you see a lower mortality rate among those that were tested than those that were not tested, well, you will reach a conclusion that testing, screening, actually saved people. All right, which leads us to the last component of the lecture, which are biases of screening. When you screen, there are three major biases that you should be aware of. The first is called the self-selection bias, the second is called the lead time bias, and the third is called the length bias. All right, so self-selection bias. Self-selection bias actually resembles something called sampling bias or self-selection, even in research studies, it's more self-selection bias. And basically the idea that those that voluntarily come to your screening program to be screened, they systematically differ from those that refuse to get screened or they do not come screened. And the way they differ will impact the outcome of their disease, the outcome of their mortality and morbidity. So if you consider that healthier people, those that are more educated, those that actually have better resources, they have better access to treatment, these are the people that end up being screened versus people that have a lower educational background, they have a lower income, lower access to medication that do not get screened. And therefore, when you start comparing screened population to non-screened population in terms of mortality and morbidity, you're going to notice that screened people or population are doing better. And that could be not because of the screening, but because they have underlying factor that actually put them at an advantage. So this is called self-selection. So let me read the slide. Those who come for screening are usually more healthy or health aware and involved in healthier lifestyle than those who do not come for screening. So you're starting off with a healthier population, a better population. They also tend to have a better adherence to treatment and as such have a better prognosis and mortality rate, which mean that the difference in mortality rate is not due to early detection, rather the fact that those screened had better self-characteristics to start with. Okay, so self-selection bias is you end up having quote-unquote healthier population that are screened than quote-unquote unhealthy population that is not screened. And when you look at the outcome, you're going to see something, a better outcome, and that has nothing to do with the screening. It's actually about who got to be screened. All right, the second bias is the lead time bias, and that is when you're going to reach a conclusion that screening increased the survival of individuals, that actually is not true. It is just because you captured the disease earlier. To explain the lead time bias, the best way is to look at this graph right here. Consider we have two women. Both of them were at 35 years of age when the biological onset of the disease started. Okay, so both women, they had the disease when they're 35 years old. Okay, now when they become 40, both of them, the disease became detectable by screening for both. So far they're exactly the same. The disease started exactly the same time. Okay, I'm going to jump into the end just to show you that the end was the same as well. Both of them died at age 46. Okay, so far the disease started the same time, the disease became detectable at the same time, they died at the same time, so obviously there's no difference between them. But notice what happened. At age 41, woman A went for screening and she was diagnosed. Woman B did not go for screening. At age 43, her symptom developed and then she was diagnosed. Okay? So, since both of them died at age 46, woman A was diagnosed at age 41, so we think that she survived for 5 years. Woman B was diagnosed at age 43, so we think she survived only 3 years, whereas in reality there is no difference. All you did is you captured the disease earlier for woman A than for woman B, and therefore you're reaching a wrong conclusion. You're saying, well, see, those that screen tend to live 2 years longer than those who were not screened. And that is not true. It's just that you captured the disease 2 years earlier. That error is called the lead time bias. Now, how do we fix the lead time bias? One way is to check for age-specific death rate. Now, you remember from our previous lectures what age-specific death rate. Obviously, if I go back to the slide, since they both died at the same age, then their age-specific death rate is going to be the same. That's one way. Another way is if you kind of like figure out the lead time, you can kind of account for it in your analysis. That's just a statistical way to do it. Then we come to the third bias. And the third bias is kind of like similar to the second one, except it's not that you're capturing the disease earlier. It's just some people have a higher chance of being detected. And then I'm going to go over the slide and you're going to understand it. So remember, the preclinical period, this is the period of time where you can screen and you can find the disease. Well, it turns out that some people have a preclinical period that is longer than other people. So maybe you have a group of people that have a preclinical for the same disease. Their preclinical is 2 years, whereas other people, their preclinical is 4 years. Now, obviously, when someone has a preclinical of 4 years, then they have a longer period of time to be screened and to be detected. So the slide continues and says, those with a longer preclinical period are more likely to be detected by screening, just because they had more time to be detected while still preclinical, right? I mean, if you have two people and one has 2 years to be detected and the other one has 4 years to be detected, well, the 4 years have a longer period and therefore you have a higher chance of detecting that person. And therefore, overrepresentation among the screen-detected cases of those with the long preclinical phase of the disease and thus more favorable outcomes. So let me explain that sentence. Since those that have a longer preclinical period have a higher chance of being screened than those with a shorter, then if we were to categorize people with a disease who eventually get the disease, short preclinical and long preclinical. And the screening test is gonna obviously has an overrepresentation of the long preclinical than the short preclinical. Now, here's where the bias actually impacts your results. Those that have a long period of preclinical, they tend also to have better prognosis. And therefore, you're going to have an overrepresentation of the better diseased in the screening, and you're going to conclude that screening helped. I have more slides. I hope it will explain better. Thus, most of those with longer preclinical period will be collected among the screen group, thus bias the survival rate. It is very difficult to account for this bias, though the literature has some ways to account it. But I think what I want to do is I want to show you this slide because hopefully that is going to help you understand. So let's suppose that we have a disease. We haven't screened yet. And 50% of those that have the disease have a short preclinical, and 50% have a long preclinical. And let's say short, 3 months, long is 9 months. Okay. The average survival rate is 6 months. Okay, so 50-50. Among the screen, the detected will be 20% short preclinical and 80% long preclinical. Okay, now why? Well, remember we mentioned that long preclinical have a higher chance of being detected. So بدل ما يطلع عنا بالscreen 50-50, you end up having an overrepresentation of the preclinical. And since instead of having 50-50, you're getting an 80-20, and since the survival for those that are long preclinical is longer than the short, you end up with an average survival of 6.8 months, which is larger than 6 months, and therefore you end up concluding that the screenings prolong the survival, which is not true. It's just It's just a length bias. Okay. All right. I guess this concludes lecture. Um, you have more material on Blackboard. Please go and check the material on Blackboard. I'm going to I'm going to send an email where I'm going to request from you things to do. I hope you enjoyed the lecture. Thank you for your time.